Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm grateful to the society for having me with you today. Thank you for the opportunity. I'll be talking today about headaches in outpatient settings mostly. And I have nothing to disclose in relation to my talk. My objective will be covering, first of all, the international classification of headache, focusing even on the website of the classification is very helpful. Then I'll talk about differentiating primary versus secondary headaches with special attention to red flags that makes us consider secondary headache workups. I'll be talking more in depth about migraines because of its significance, and a little bit about more headaches, other headaches. Disease burden. Headaches are very common. 40% of the world population is affected by headache. Frequently happens in young ages, affecting family interaction, affecting work and income. So it's really major. It's one of the major disabilities in neurology in different ages. Now, when we move about to talk what primary and secondary headache means. Secondary headache is when you have another disorder causing headache. Like you have sinusitis, meningitis, intracranial hemorrhage causing headache, that's secondary headache. It's less common than primary headaches. When we talk about migraine or tension headache are much more common, maybe more than 90% of the headaches. It's important to say secondary headache has a reason, whereas primary headache has risk factors or triggering factors. The patient will frequently ask you, why do I have migraine? I'll tell them there's no specific reason. Your body has the potential for migraine, but you have risk factors, your age, your family, your female gender, and so on. And you have triggering factor, which are specific smells, food, hormonals. In secondary headache, more urgent attention to the underlying etiology versus in primary headache, some reassurance and addressing the headache itself. Red flags, you can remember the SNOOPs. SNOOPs are the mnemonic to remember for red flags for headache to consider secondary etiology. Systemic signs make you think of giant cell arthritis, let's say, weight loss, maybe malignancy, neurological sign, intracranial pathology, onset when it's sudden. You're talking about, is it thunderclap headache, subarachnoid hemorrhage, for example. Older age at onset, again, malignancy, giant cell arthritis. When it's a progressive rather than fluctuating, it's concerning. Papilledema makes you consider intracranial pressure pathologies. Pregnancy is a hypercoagulable state, makes you consider venous sinus thrombosis, and positional changes or triggering by Valsalva makes you also consider ICP pathology or colloid cyst, let's say in the third ventricle. I really would like you to take a look on the website. Just Google International Headache Classification, and you'll find it. Start by talking about primary headaches, which on the left you see migraines, tension type, trigeminal autonomic cephalgias, including cluster. Then it moves to the secondary headache due to another pathology disease. Then part 3, neuropathies and neuralgias. It's very helpful to start your search about any specific headache on this website. You have a nice search field. You can put in any term that you think you would like to know a little more about and see how it's related to headaches. It's a very helpful website. Then you'll need to read more because the website is focused on classification and diagnostic criteria, but it's a good start. The two most common headaches are migraine and tension headaches. Duration up to, this is 72 hours in migraine, not 27. 3 days, 4 hours to 3 days. Tension headache, 30 minutes to 7 days. The rest of the criteria are almost the opposite. You need 2 out of 4 criteria for each, and they're the opposite 2 to 4, meaning for migraine, unilateral, throbbing, moderate to severe, worse with routine activity, and you need only 2 out of 4, so still can be a migraine, although it's bilateral, can be a migraine, although it's not throbbing. 2 to 4 are enough. The opposite for tension, bilateral, non-pulsating, mild to moderate, not affected by routine activity. And the associated symptoms for migraine, you need either both photophobia and phonophobia or nausea, with or without vomiting, whereas in tension, you cannot have nausea, and you cannot have both photophobia and phonophobia. Tension headache is more common, 26% global one-year prevalence compared to 15% migraine, but we see migraine more often just because it's more severe, so more likely to seek medical attention. Migraine with aura is worth talking about. What I just mentioned here was migraine without aura, which is a headache disorder. Migraine with aura is not necessarily a headache disorder. Migraine with aura is mostly transient focal neurological symptoms, usually precedes or accompany headache, but you don't need to have headache to diagnose migraine with aura. You can have esophageal migraine, which is migraine without headache, the aura itself. The aura is a transient neurological symptom, visual, sensory, motor, hemiplegic migraine, brainstem. And the aura has to meet 3 out of 6 criteria to think it's likely a migraine aura. It takes 5 or more minutes to progress. It's not an abrupt aura. It can spread from one aura to the next in succession, meaning like visual aura when the occipital lobe is involved, then moves to sensory aura when it radiates to the parietal, let's say. The aura is unilateral and lasting no more than 60 minutes. One of the criteria you see with a red line can be accompanied or followed by headache, doesn't have to be. When it's a brainstem aura, you get the brainstem symptoms on the right, vertigo, diplopia, dysarthria, and such. Talking about migraine pathophysiology, no longer the vascular theory is the correct one. We used to say vasoconstriction gives aura, vasodilation gives headache. That's no longer the case. We're talking about cortical spreading depression and neurogenic inflammation. You see the cortical spreading depression is depolarization of neurons in a wave spreading from, let's say, starts from occipital, goes to the parietal, for example. That's what gives you the visual aura. Then sensory aura can happen back to back, and it spreads slowly over the cortex, about 2 to 6 millimeters per minute. That's why it takes at least 5 minutes to complete the progression of one aura, cannot be abrupt. When it reaches the aura itself, that cortical spreading depression triggers the terminals of the trigeminal nerve, goes to the trigeminal ganglion signal. Then whenever the trigeminal vascular system is stimulated, it releases neuroinflammatory chemicals in the branches and terminals on the meninges and the vessels of the meninges. That what gets eventually perceived on the right. We see like the dura, the neurogenic inflammation transmitted to the thalamus, where it's perceived as pain, and from thalamus as a relay station, signal goes to the whole cortex to different locations, which can cause other symptoms, anorexia, photophobia, mood swings, whatever. So we don't know a lot about cortical spreading depression and migraine pathophysiology, but that's what we think is going on, but that's not like certain and definite. Migraine treatment, you'll start by lifestyle modification, then focus on what's the abortive treatment plan, and more importantly, what's the preventive treatment plan, and screen your patient always for medication overuse headache. The lifestyle modification, the seeds, sleep, enough sleep, exercising, eating regularly, not skipping meals, diary of headaches can help recognizing patterns, hormonal relation with the menstrual period, and reducing stress is very essential. And some people have their own unique triggering factors that has to be addressed also. Preventive treatments used to be mostly the propranolol, the tricyclics, the anti-epileptics, especially topiramate. These are good, but has a high adverse reaction profile, unfortunately. And the newer medications will address CGRP, which we have the CGRP monoclonal antibodies and antagonists, with gepants. We have pills, injections, every 3 months, quarterly infusions. We have multiple options, and the Botox injections. I mentioned the CGRP. It's one of the neurotransmitters that when I talked about the trigeminal vascular systems, it's one of the neurotransmitters or the chemicals released. And when we block it with one of those newer medications, we achieve multiple things. So here we have the signal itself. It's a neurotransmitter, so we can block the signal by blocking CGRP, so the migraine signal stops. Here, it's also a neurogenic inflammatory chemical, so when we block it, we're preventing that neuroinflammatory response in the meninges that will be perceived eventually as headache. Although it prevents vasodilation by blocking the CGRP, thanks God, it does not cause vasoconstriction as triptans used to do. So that's a very good new feature. Then we move on to abortive treatments, and we have the simple stuff you all already know, but in addition to that, triptan, DHE, with its contraindications, unfortunately, coronary artery disease and controlled hypertension, and the new, again, is gepants, which antagonizes CGRP. Antiemetics are very helpful in aborting migraines. You'll watch your patient for a medication overuse headache whenever they're using more than 15 days a month of acetaminophen or NSAIDs, or they're using more than 10 days a month of most of the other abortive treatments. They can develop medication overuse headache, creating a new type of headache more than 15 days a month, and can be more difficult to treat than the original headache they started with. Thanks God, as of now, CGRP acting medications are not reported to cause medication overuse headache. So this is considered a secondary headache, definitely. Tension type headache, as we said, diagnostic criteria are almost the opposite to migraine, and prevention is with tricyclics, mostly less of an issue unless the patient overuses medications. But if it's infrequent and they're using acetaminophen, that's okay. When we say chronic daily headache, it's not specific type of headache. It's any headache that reaches more than 15 days a month for more than 3 months, and typically it's either chronic migraines or chronic tension headache, hemicrania continua, new daily persistent headache, and occasionally it's a secondary headache like medication overuse headache when the patient overused their abortive treatment. When I say trigeminal, you may think of trigeminal neuralgia, but also don't forget trigeminal autonomic cephalgias. Trigeminal neuralgia is under part 3 in the neuralgias and neuropathies, whereas trigeminal autonomic cephalgia is under part 2 as a primary headache. I'll start, although you're possibly, trigeminal autonomic cephalgia includes a cluster in addition to other headaches. We'll start by talking about it since it's a primary headache, then I'll move to trigeminal neuralgia. Trigeminal autonomic cephalgias are called autonomic because they are unilateral headache accompanied by autonomic features like nasal congestion, runny nose, tearing eye, miosis, mydriasis, something like that. Frequently, a sense of restlessness or agitation accompanies, especially in cluster headaches. Trigeminal autonomic cephalgias are classified according to their duration. Cluster, the typical 15 minutes to 3 hours. When it's more than 3 months on the same side, even with some intermittent nature to it, hemicrania continua. 2 to 30 minutes, paroxysmal hemicrania, and much shorter, up to 10 minutes, Sankt and Suna, rare headaches. Paroxysmal hemicrania and hemicrania continua are called indomethacin responsive headaches. So remember, try to make the diagnosis when you get those too much autonomic features, because the treatment can be unique and can be very effective with indomethacin. And don't go to the diagnosis, however, with any autonomic features, because you can see some autonomic features even in migraine. So it's some runny nose or congested nose, you cannot call it cluster headache. I'm moving to trigeminal neuralgia. Very brief, less than 2 minutes, sharp electrical headache in the trigeminal distribution. Most importantly, precipitated by non-painful stimulation, like touching the face, shaving, brushing teeth, something like that. Other neuralgias can include glossopharyngeal neuralgia in the throat, nervous intermedius neuralgia in the ear area, mastoid. Other neuralgias include occipital, supraorbital, and supratrochlear. Very easy to diagnose if you touch and feel those points, and easy to treat with injection nerve block, and very easy to miss if you don't do it right, and it can be difficult to treat and can fail to treat with the other medications. Occipital protuberance, mastoid, 3 sections at each point here, greater occipital, lesser occipital, and these are at the side, edge of the orbit. You can feel them. Pressing over those points can trigger a radiating headache, which can help the diagnosis. Practical point is talking about sinus headache. When the patient tells you, I have pressure in my head, congested nose, and it's affected by weather change, and they make their own diagnosis of sinus headache, that can be a major mistake, and start taking antibiotics, because all of those features can be prominent features of migraine. It's triggered by barometric pressure changes, so weather changes. It can be with facial tenderness and heaviness, and all of very similar. So one of the studies, I think, found more than 90% maybe of what's called sinus headache is actually migraine. Vision and refractive error can be a factor, but it's not that common. So when the patient is focusing at the computer, although it can worsen the headache when they have refractive errors, it's also a very common migraine trigger. So think of migraine, it's much more common than sinusitis or refractive error induced headache. So how do we approach diagnostically a headache person? We start by their history. We focus on those points. When we speak about the duration, make sure you're talking about untreated duration. When the patient tells you my headache lasts 2 hours, and you start thinking it's a cluster headache, but actually that's only when they take their acetaminophen, let's say. And when you ask them how long does it last when you don't take your medicine, and it's 6 hours or half a day, you're dealing with a migraine. So you don't want to make the wrong diagnosis and the treatment plan by missing the untreated duration. Is it bilateral, unilateral, sudden, gradual, attacks, associated symptoms, triggers? All of that will make your diagnosis. And you move on to physical exam. Usually it's a normal physical exam in headache patients, other than a papilledema on fundoscopic exam, or significant tenderness on occipital, supratrochlear, supraorbital, but don't over-interpret those signs, because also migraine is accompanied by sensitization. What we call sensitization means that whole trigeminal vascular system is irritated, and you can get the same sensitivity to pressure points. So still stay open to possibilities. Pericranial muscles can be tender in tension type headaches, and allodynia in migraine is common. Since I mentioned sensitization, remember when we treat migraine, we try to treat it as early as possible. The late we are, when sensitization happens, trigeminal system is active already, can be more difficult to intervene on it and to control it. Now, to image or not to image, that's the question. And when it's just a regular meeting migraine criteria or tension criteria, no red flag, don't image. It's a waste of money and time. You may find white matter abnormalities in migraine. We call it migraine vasculopathy. Doesn't help you, doesn't make any difference. Trigeminal neuralgia and other will have to rule out intracranial pathology, and don't miss the possibility of giant cell arthritis. Check ESR, CRP, and ask about jaw claudication, minor misalignment in the eyes, or diplopia. And thank you very much, and have a headache-free day. Sorry it was very quick run. I appreciate your time.